This lecture is over Chapter 37, Care of Patients with Shock. Begins on page 751. Some of the concepts we're going to talk about are perfusion and immunity, and interrelated concepts include clotting and gas exchange. So what is shock? Shock is widespread abnormal cellular metabolism that occurs when gas exchange with oxygenation and tissue perfusion needs are not met sufficiently to maintain cell function. So basically that oxygen-rich blood that should be flowing through our vessels is not occurring. It can occur for different reasons, but the main thing that occurs regardless of the cause with shock is that oxygen-rich blood isn't getting to tissues and vital organs. Any problem that impairs perfusion and gas exchange to tissues and organs can start the syndrome of shock and lead to a life-threatening emergency. Shock is often the result of cardiovascular problems. It can be classified as hypovolemic shock, cardiogenic shock, distributive shock, and obstructive shock, and we'll talk about each of those different types. Most signs and symptoms of shock are similar, regardless of what starts the process or which tissues are affected first. It is considered a whole body response or syndrome and a life-threatening emergency. Before we get on to the different types of shock, look at page 752, Review of Gas Exchange and Tissue Perfusion. Gas exchange and perfusion depend on how much oxygen from arterial blood perfuses to tissues. Perfusion is related to mean arterial pressure. The factors that influence mean arterial pressure include total blood volume, cardiac output, and size and integrity of the vascular bed, especially capillaries. A decrease in either total blood volume or cardiac output will lower the mean arterial pressure. Some nerves continuously stimulate vascular smooth muscle, so the blood cells are normally partially constricted, a condition called sympathetic tone. Increases in sympathetic stimulation constrict smooth muscle even more, raising the mean arterial pressure. Perfusion or blood flow to organs adjusts to changes in tissue oxygenation needs. The body can selectively increase blood flow to some areas while reducing flow to others. The skin and skeletal muscles can tolerate low levels of oxygen for hours without dying or being damaged, while other organs such as the heart, brain, liver, and pancreas do not tolerate hypoxia, and a few minutes without oxygen can result in serious damage or cell death. So the types of shock that we're going to talk about: hypovolemic, cardiogenic, distributive, and obstructive. If you look at table 37.1 on page 752, it describes the different types and then gives examples or causes for each different type of shock. More than one type of shock can be present at the same time, but first we'll talk a little bit about hypovolemic shock. Hypovolemic shock occurs when too little circulating blood volume decreases mean arterial pressure, resulting in inadequate total body perfusion and gas exchange. Common problems leading to hypovolemic shock are dehydration and poor clotting with hemorrhage. Cardiogenic shock occurs when the heart muscle is unhealthy and pumping is impaired. Myocardial infarction is the most common cause of direct pump failure. Distributive shock occurs when blood volume is not lost from the body but is distributed to the interstitial tissue where it cannot perfuse to organs. It can be caused by blood vessel dilation, pooling of blood in venous and capillary beds, and increased capillary leak. It can then be categorized as neural-induced or chemical-induced. Neural-induced distributive shock occurs when sympathetic nerve impulses are decreased and blood vessel smooth muscles relax, causing vasodilation and poor perfusion. Chemical-induced distributive shock has three common origins: anaphylaxis, sepsis, and capillary leak syndrome. It occurs when certain body chemicals or foreign substances in the blood and vessels start widespread changes in blood vessel walls. An anaphylaxis, that is an extreme type of an allergic reaction. The result is widespread loss of blood vessel tone with decreased blood pressure and cardiac output. Sepsis is a widespread infection that triggers a whole body inflammation. It leads to distributive shock when infectious microorganisms are present in the blood and is most commonly called septic shock. Capillary leak syndrome is the response of capillaries to the presence of histamine and other chemicals that enlarge capillary pores and allow fluid to shift from the capillaries into interstitial tissue. If you look at distributive shock in table 37-1 on page 752, you'll also notice that burns is a cause for distributive shock. So you should be linking burns and the fluid shift that we talked about in that chapter with distributive shock. Finally, obstructive shock is caused by problems that impair the ability of the normal heart to pump effectively. The heart itself remains normal, but conditions outside of the heart prevent either adequate filling of the heart or adequate contraction. Cardiac tamponade is the most common cause of obstructive shock. And we've talked about cardiac tamponade in the last lecture, and that's when fluid builds up in that sac that surrounds the heart and makes it difficult for the heart to function properly. Although the causes and initial signs and symptoms associated with the different types of shock vary, eventually the effects of hypotension and anaerobic cellular metabolism, which is metabolism without oxygen, result in the common key features of shock listed in chart 37-1. And again, you can see those key features on chart 37-1 on page 752. So you want to go ahead and review those, and there'll be signs and symptoms that you should associate with poor perfusion and poor oxygenation. So first we're going to talk about hypovolemic shock. It is your exemplar. So basically your lecture will focus on hypovolemic shock and also septic shock. The basic problem of hypovolemic shock is loss of vascular volume resulting in a decreased mean arterial pressure. The reduced mean arterial pressure slows blood flow, decreasing tissue perfusion. The loss of red blood cells decreases the ability of the blood to oxygenate the tissue it does reach. These gas exchange and perfusion problems lead to anaerobic cellular metabolism. The main trigger leading to hypovolemic shock is a sustained decrease in mean arterial pressure from decreased circulating blood volume. A decrease in mean arterial pressure of 5 to 10 below the patient's normal baseline value is detected by pressure-sensitive nerve receptors or baroreceptors in the aortic arch and carotid sinus. This information is transmitted to the brain, which stimulates compensatory mechanisms to ensure continued blood flow and oxygen delivery to vital organs while limiting blood flow to less vital organs. The movement of blood into selected areas while bypassing others is called shunting and results in some of the shock symptoms. If the events that cause the initial decrease in mean arterial pressure are halted, compensatory mechanisms provide adequate gas exchange and perfusion without interventions. If events continue, the mean arterial pressure decreases further. Some tissues function under anaerobic conditions. This condition increases lactic acid levels and other harmful metabolites. These substances cause acidosis with tissue-damaging effects and depress heart muscle activity. The effects are temporary and reversible if the cause of shock is corrected within 1 to 2 hours after onset. When shock continues for a longer period of time without help, the resulting increased metabolites cause so much cell damage in vital organs that they are unable to perform their critical functions. When this happens, when this problem, known as multiple organ dysfunction syndrome, occurs to the extent that vital organs die, recovery from shock is no longer possible. If you look at table 37-2, it summarizes the progression of shock from the initial stage to the refractory stage. So shock can be divided up into 4 different stages: initial, non-progressive, and progressive, and finally refractory. During the initial stage, is present when the patient's baseline mean arterial pressure decreases by less than 10. Compensatory mechanisms are often effective at returning systolic pressure to normal. Thus, oxygen perfusion to vital organs is maintained. Cellular changes include increased anaerobic metabolism in some tissue with production of lactic acid, although overall metabolism is still aerobic. The compensation responses of vascular constriction and increased heart rate are effective, and both cardiac output and mean arterial pressure are maintained within normal range. Because vital organ function is not disrupted, the indicators of shock are difficult to detect at this stage. At the bottom right of 754, you have a yellow box. Be aware that increased heart and respiratory rates or a slight increase in diastolic pressure, blood pressure may be the only sign of this stage of shock. Non-progressive stage of shock occurs when the mean arterial pressure decreases by 10 to 15 from the baseline. Kidney and hormonal compensatory mechanisms are activated because cardiovascular responses alone are not enough to maintain mean arterial pressure and supply oxygen to vital organs. So the ongoing decrease in mean arterial pressure will trigger the release of renin, antidiuretic hormone, aldosterone, epinephrine, and norepinephrine. Urine output will decrease. Sodium reabsorption increases with water following. Widespread blood vessel constriction will occur. Antidiuretic hormone increases water reabsorption in the kidney, further reducing urine output and increases blood vessel constriction in the skin and other less vital tissue areas. Together, these actions compensate for shock by maintaining the fluid volume within the central blood vessels. In the non-progressive stage, tissue hypoxia occurs in non-vital organs and in the kidney, but it is not great enough to cause permanent damage. Buildup of metabolites from anaerobic metabolism causes acidosis and increased blood potassium levels. If you remember, with acidosis, the potassium is high. Alkalosis has low K, or low potassium. So with shock, you'll see acidosis and increased blood potassium levels. Signs and symptoms of this stage include changes resulting from decreased tissue perfusion. Subjective changes include thirst and anxiety. Objective changes include restlessness, tachycardia, increased respiratory rate, decreased urinary output, falling systolic blood pressure with a rising diastolic blood pressure, narrowing pulse pressure, cool extremities, and a 2% to 5% decrease in oxygen saturation. Comparing these changes with values and observations obtained earlier is critical to identifying this stage of shock. So with shock, well, with any patient, but especially with shock, we want to monitor for small changes or trends that alert us to the patient declining. If the patient is stable and compensatory mechanisms are supported by interventions, he or she can remain in this stage for hours without having permanent damage. Stopping the conditions that started shock and providing supportive interventions can prevent shock from progressing. The effects of this stage are reversible when nurses recognize the problem and start the appropriate interventions. Progressive shock occurs when there's a sustained decrease in mean arterial pressure of more than 20 from baseline. Compensatory mechanisms are functioning but can no longer deliver sufficient oxygen even to vital organs. Vital organs develop hypoxia, and less vital organs become anoxic and ischemic. As a result of poor perfusion and a buildup of metabolites, some tissues die. Indications of the progressive stage include a worsening of changes resulting from a decreased tissue perfusion. The patient may say they feel as if something bad is happening. They may be confused. Their thirst will increase. Objective changes include rapid weak pulse, low blood pressure, pallor cyanosis of oral mucosa and nail beds, cool and moist skin, anuria, and a 5% to 20% decrease in oxygen saturation. Lab data may show a low blood pH along with rising lactic acid and potassium levels. The refractory stage occurs when too much cell death and tissue damage resulting from too little oxygen reaching the tissue occurs. Vital organs have extensive damage and cannot respond effectively to intervention, and shock continues. So much damage has occurred with the release of metabolites and enzymes that damage to vital organs continue despite interventions. The sequence of cell damage caused by the massive release of toxic metabolites and enzymes is termed multiple organ dysfunction syndrome.